We, the Autism Center of Excellence, are happy to hold the 18th lecture webinar that is part of a series of webinars for Autism Awareness Month of April 2020 via Zoom. Those webinars, presented by Autism Center of Excellence, aim to increase awareness about autism spectrum disorder among our community and provide resources to service providers. This is Malak Armudi, a senior speech-language pathologist at the Autism Center of Excellence, and today is Sunday, April 19th of 2020. And today, Dr. Sultan Alfawaz will present a lecture titled The Multidisciplinary Feeding Clinic Lessons from US. Dr. Sultan Alfawaz is a Saudi Arabian occupational therapist recently relocated to Riyadh. He was based in Los Angeles, California for over 10 years. His expertise in child development, air sensory integration, autism, and sensory feeding. He obtained his bachelor's with honors in occupational therapy at Brunel University, his post-professional master's and post-professional clinical doctorate in occupational therapy at the University of Southern California. Dr. Alfawaz completed his clinical residency at Pediatric Therapy Network, Torrance, California in 2013. His doctoral thesis focused on norming the new test, Structured Observations of Sensory Integration Motor, SOSIM. He has worked and volunteered in Saudi Arabia, Mexico, the United Kingdom, and the United States. Dr. Alfawaz was the first Saudi occupational therapist to obtain the American Board in Occupational Therapy and SIPT certification in 2012, and to achieve a post-professional clinical doctorate in occupational therapy. He's an internationally and locally recognized clinician and lecturer. He currently leads the Middle East and North Africa normative data collection for the evaluation of air sensory integration. Dr. Alfawaz is the coordinator of air sensory integration certification courses at Al Faisal University in Riyadh, Saudi Arabia. Dr. Alfawaz has joined the ACE team this month as the Director of the Occupational Therapy Services. We are honored to have you, Dr. Alfawaz, and go ahead, start.
Thank you, Ms. Malak, and thank you for all the participants who tune in and joined us in this lecture. Thank you, Ms. Al-Malak, for this generous introduction. I hope, inshallah, within Al-Maghrib time, you have your coffee and your mind is ready for this quite interesting, I would say, lecture. So today we'll talk about the multidisciplinary feeding clinic, and I will share with you a lesson from the US as I shared 10 years of my life in California.
Okay, Dr. Sultan, I would like just to share with you the poll. 48% of your audience are occupational therapists, 16% are speech-language pathologists, and we have pediatricians, psychiatrists, and dietitian, and neurologists too.
Awesome, awesome, awesome. Great to hear. Hopefully this lecture will be beneficial for all those professionals. All right, I'm ready to start. Allah taqabbal salat al-maghrib min al-jami', and we're going to start right now. Bismillah. So today's talk, we're going to cover the following. I'm going to briefly talk about autism definition and prevalence, because I'm sure many of you guys are professionals and are aware about the definition and prevalence. I will talk about the OT unique role in feeding. I will as well talk about the difference between feeding, eating, and swallowing. And then I will talk about the newly defined or the new framework of pediatric feeding disorders. And then I will deviate a little bit more and talk about the multidisciplinary feeding clinic. I'll give you guys examples from the US. And then by the end, I hope I will be able to convince you about the importance of having multidisciplinary feeding approach. And I will share with you my clinical, during my clinical doctorate, We advocated for a mealtime assessment clinic at CHLA, Children's Hospital of Los Angeles, during my clinical residency, and we were able to expand the feeding clinic. And hopefully that will give you a tool to utilize at your center or place of work in order to advocate for the need, or the dire need, I would say, for feeding, for multidisciplinary feeding approach in Saudi and the region. So when we hear April, what do we think of? For a student, maybe it's a time to celebrate spring break, right? Perhaps for some of you, it's a wedding anniversary. For some, maybe it's a birthday month, or simply for majority of you guys, it's just one out of the 12 months of the year, right? But for me, April is a very special month. Not only because I was born in April, but in our therapy world, we celebrate both Occupational Therapy Awareness Month and Autism Awareness Month. Isn't that awesome that OT and autism share the month of April? That would be great. It's not great just because of the awareness, because we as occupational therapists play a great role in intervention with individuals with autism. So I thought I will shine on a light on one of the many critical roles occupational therapy play in everyday lives for individuals with autism. We occupational therapists play a critical role with the ASD individuals who have feeding challenges. Therefore, I decided to pick tonight's topic. So let's briefly define autism. Many of us know that ASD is a complex developmental condition that involves persistent challenges in social interaction, speech and nonverbal communication, and restricted repetitive behavior. The effect of ASD and the severity of the symptoms are different in each individual. A diagnosis of ASD now includes several conditions that used to be diagnosed separately. In the past, autistic disorder, pervasive development disorder, not otherwise specified, and Asperger's syndrome were different diagnoses. Now they all under one umbrella called ASD, Autism Spectrum Disorder. We may all aware that the CDC, the Center for Disease Control and Prevention, released its biennial update of autism. The estimated prevalence among the US children based on the analysis of 2016 medical and school record of 8 years old from 11 different areas or sites across the United States. And as many of us working with these individuals or with this population, we know that there is an increase in the prevalence. So now 1 in 54 children by age 8 have a diagnosis of ASD in the United States. Boys are 4 times as likely to be diagnosed as girls. This may indicate the need for more research to understand the gap in prevalence and ensure that our beloved girls with autism are receiving the care they need. So, how does OT help kids with autism? We all know that autism is a spectrum and it's a lifelong condition associated with varied course from early childhood through adulthood. We occupational therapy practitioners are distinctly qualified to support productive and meaningful participation in everyday occupation. What I mean by occupations, like activities. Community activities that enhance quality of life for individuals with ASD and this is really, really important, and their families. Because of our expertise in activity and environmental analysis, we occupational therapists are particularly skilled in using evidence-based strategies to address self-regulation, sensory needs, feeding, adaptive skills, motor development, mental health, social participation, and daily life skills. One key role as well occupational therapists play is in the early detection of autism, and they make recommendation for services that are associated with positive outcome. Many diagnostic clinics of autism will have occupational therapists part of their team. So we occupational therapists in that early stage discuss and support the families by discussing the typical developmental milestone, promote engagement in age-appropriate activities, and provide community resources that support active participation. So as I have mentioned earlier, in April, we occupational therapists celebrate our OT Awareness Month. We celebrate how we, as a practitioner, embrace challenges to enhance lives. So let's use this opportunity to outline our contribution to feeding challenges. I think we all agree that feeding and eating are vital occupations that provide nutrition and sustenance in the life of a young child. Mealtime experiences provide opportunity for social connectedness, sharing of experiences, and the development of traditions and food practice within family and culture. And I'm sure many of you guys feeling that during this pandemic. When a child is identified as having an underlying disorder of feeding, the feeding relationship between a parent and child is disrupted. This contributes to further challenges with overall family function, which can lead to problematic feeding practices. Thus, when occupational therapy practitioners address feeding, eating, and swallowing concern, they usually collaborate and actively involve the family member or the caregiver and other profession. So that's why we believe a collaborative approach is paramount. Occupational therapy long-standing expertise and activity of daily living include involvement in feeding, eating, and swallowing performance of individuals across the lifespan. We OT practitioners fulfill a valuable role when we work with children with feeding disorders. OTs hold a unique perspective in understanding attitudes, family values, culture component to provide a context for the mealtime experiences, as well as the skills to assess the oral motor and the sensory motor component of feeding. So I think we all know that feeding, eating, and swallowing are complex activities that require effective, coordinated function of the motor, sensory, and cognitive systems. So any problem can widely range and may include physical difficulty, for example, bringing food to mouth, or processing food in mouth, for example, motor or sensory deficit, dysphagia, psychosocially based eating disorder, for example, food obsession, maladaptive eating habit, dysfunction related to cognitive impairment, for example, understanding nutrition or food preparation, some surgical intervention and neurological impairment, as well as positioning problem or posture that may affect feeding, eating, and swallowing. So intervention focused on occupation of daily living include usually facilitating an individual ability to participate in feeding and eating activity that are valued and meaningful to that person, such as learning to eat independently, joining friends for lunch, or for the parent to feed their beloved child. So we believe as OT practitioners that we fulfill a valuable role when working with children with feeding disorders. So let's define feeding, eating, and swallowing from an OT lenses. So feeding, eating, and swallowing are interdependent activities, and definition of each term overlap in literature sources. Broad definitions are well noted in the AOTA literature. So what I mean by AOTA, American Association of Occupational Therapy. So they define the following term as, and I'm quoting, feeding is the term used to describe the process of setting up, arranging, and bringing food or fluid from the plate or cup to the mouth. Sometimes we call it, as occupational therapists, self-feeding. However, eating is defined as the ability to keep and manipulate food or fluid in the mouth and swallow it. Eating and swallowing are often used interchangeably within the OT domain. So feeding and eating are essential to human functioning for nourishment of the body, and it's a form of social interaction. It's involved in many facets of person culture, from leisure to professional activities. Swallowing involves a complicated act in which food, fluid, medication, or saliva is moved from mouth through the pharynx and esophagus into the stomach. And I'm quoting all these definitions from the American Occupational Therapy Association. Statement on feeding. So, as I mentioned earlier, we occupational therapists, we're practicing in the US, we believe that feeding, eating, and swallowing are within the domain and scope of practice for occupational therapy. Occupational therapy practitioners have the knowledge and skill necessary to take a lead role in the evaluation and intervention of feeding, eating, and swallowing problems. As part of the evaluation and intervention process, occupational therapists consider a comprehensive management of feeding, eating, and swallowing. So we as an occupational therapist, we consider a comprehensive assessment of feeding, eating, and swallowing problems. We may use adaptive feeding equipment ranging from modified utensil to more sophisticated feeding equipment like Winsford feeder, the physical and the sensory difficulty of bringing food, liquid, or medication to the mouth, the sensory processing issue in the mouth, the oral defensivity, the texture of the food, management of mechanical devices for feeding. When we work closely with our friend in the speech department, speech therapist, when we work in dysphagia, psychosocially based eating disorder, anorexia, or bulimia. We work closely with our friend in the behavioral psychology, in disorder like selective eating, or dysfunction related to cognitive impairment or neurological impairment, such as individual with autism, or surgical intervention when we work close with our friends in the medical department. We even sometimes work really closely with our friend in the in the physical therapy department when we work on positioning or posture problem that affect feeding, eating, and swallowing. So let's talk about pediatric care, because we have many of you guys are from different professionals. So let's talk about feeding. Feeding issues are one of the most common issues seen in pediatric care, affecting 25% of typically developing children, 90% of children with disability, and according to Silverman in 2010, approximately 1/2 to 2/3 of children with feeding disorder present with mixed causes that include behavioral, psychological, medical, and developmental factors. Therefore, when assessing and treating a child with feeding issues, multiple interrelated factors need to be considered. In the US, children with complex feeding or with feeding challenges usually need and require more care, which leads a lot of families, especially in the rural areas, to seek care in urban areas or metropolitans, where there are university hospitals or more specialized hospital, where more medical teams and specialty services are available. So we are in April. Let's talk about challenges and feeding challenges with individuals with autism. So in Bandini's article 2010, she assessed food selectivity or picky eating as we observe it in young children, and it's a frequent cause for parental concern. Food selectivity is more commonly reported in children with developmental disabilities than in typically developing children, particularly in children with autism. So in her study, they studied food selectivity in children with autism and food selectivity in typically developing children. So food selectivity, it was defined to comprise three domains: food refusal, limited food repertoire, high frequency single food intake. So food refusal and high frequency single food intake were assessed using a modified version of the Youth and Adolescent Food Frequency Questionnaire. Many of the dietitians may be familiar with this questionnaire. Whereas limited food repertoire was assessed using 3-day food record or a log. Food refusal was assessed based on the absolute number of food that parent indicated that the child wouldn't eat, as well as the percentage of the food that the child wouldn't eat relative to the number of food that were offered. Food frequency questionnaire was modified for parents to quantify how many food children refused and whether children ate a large number of the same food on a daily basis. Frequent food questionnaire contained 131 food items in comparison with the original one of 126. Parents were asked to write in food that were not included in the in the 131 question. High frequency single food intake was defined as single food written by the parent that children ate more than 4 to 5 times per day. Limited food repertoire is how many unique food, including beverages, each child consumed over a 3-day period. In order to determine nutrient inadequacy of any of the child diet, they identify nutrients that were found to be low in a national representative survey of the diet of US children. These included calcium, vitamin D, E, iron, zinc, and fiber. In addition, because intake of vegetable and fruit are often below recommendation for US children, they included vitamin A and C. They concluded from their moderate size sample that 53 children with their moderate size sample was 53 children with ASD versus 58 typically developing children. And they concluded that food selectivity is more common in children with ASD than in typically developing children. Further, they have shown with their data that one aspect of food selectivity, which is limited food repertoire, is associated with inadequate intake of a nutrient. These findings suggest that limited food repertoire is or may be a concern. Many health professionals have to be aware of it. And they found that children with ASD displayed more food refusal and exhibited more limited food repertoire than did typically developing children. Food refusal behavior was present in both groups of children. And they found that the commonly held myth or belief that dietary pickness is outgrown with age was not supported by their cross-sectional findings. Furthermore, they found that among typically developing children, levels of food refusal and food repertoire were similar by age, whereas among children with ASD, food refusal, not food repertoire, was marginally lower among older children. So I hope we all know that feeding is a complex process that requires interaction of different body systems: centroperipheral nervous system, oropharyngeal mechanism, cardiopulmonary system, GI tract, and support from the craniofacial structures and the musculoskeletal system. So this requires a coordinated interaction, which require acquisition and mastery of skill. And these skills need to be appropriate for the child physiology and developmental stage. We all know in children or in the children population, feeding occurs in the context of caregiver-child dyad. Any disruption of this system places a child at risk for a feeding disorder and associated complication. So therefore, feeding disorder requires a comprehensive assessment and treatment of 4 closely related complementary domains: medical, psychosocial, feeding skills, based system, and associated nutritional complication. So previously, our previous diagnostic paradigm have, however, typically defined feeding disorder using the lens of a single profession or discipline, and failed to characterize associated functional limitations that are critical to plan appropriate intervention and improve the quality of life of children with feeding disorder. Excuse me. So many experts in the field use the framework of the World Health Organization, WHO, the International Classification of Function, Disability, and Health, to have a unifying diagnostic term. So they proposed pediatric feeding disorder, and they define it as impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skills, and or psychosocial dysfunction. Those 13 experts from 7 disciplines believe by incorporating associate functional limitation, the proposed diagnostic criteria would enable practitioner and researcher to better characterize the need of more heterogeneous patient population, and hopefully will facilitate inclusion of all relevant discipline in treatment planning and promote the use of common, precise terminology, which will be necessary to advance clinical practice, research, and healthcare policy. So I already mentioned that there were 15 experts from 7 disciplines: pediatric gastroenterology, DBP, developmental behavior pediatrics, occupational therapy, speech and language pathology, pediatric psychology, applied behavior analysis, and registered dietitian. Really, really highly recommend, if you are interested in feeding, to read this article by Godai, 2019. So the diagnostic criteria for pediatric feeding disorder: a disturbance in oral intake of nutrient inappropriate for age, lasting for at least 2 weeks and associated with 1 or more of the following: medical dysfunction, which will be assessed by a doctor, is evidenced by the following: cardiorespiratory compromise during oral feeding, B, aspiration or recurrent aspiration pneumonitis, prematurity. So the medical factor will be prematurity, impaired structure and function of the GI, impaired cardiorespiratory or neurological system, that are associated with dysphagia: upper GI tract dysfunction, which is associated with pediatric feeding disorder; oropharyngeal and laryngeal anomalies, which impair the mechanics of normal feeding; anti-inflammatory disease of the upper GI tract; and chronic constipation, which impair the normal feeding. GRD, children with a neurological impairment, as we all know, at increased risk for pediatric feeding disorder as they grow and reach a point where nutritional needs exceed their feeding skills. So generally, children with more severe motor and cognitive delays have greater feeding impairment, such as children with autism, cerebral palsy, Down syndrome, and global developmental delay. So those are the medical factors which are assessed by doctors. Still, we are in the diagnostic criteria for pediatric feeding disorder. Number 2 is nutritional dysfunction, which is assessed by a registered dietitian, is evidenced by the following: malnutrition, specific nutrient deficiency, or significantly restricted intake of one or more nutrient resulting from decreased dietary diversity, reliance on internal feeds or oral supplement to sustain nutrition or hydration. The nutritional factor, as we know, many children with pediatric feeding disorder have a restricted quality or quantity or variety of beverages, food consumed, which place them at risk of malnutrition, overnutrition, micronutrient deficiency, or toxicity, or dehydration. Many of dietitians know that the restricted dietary diversity are common in pediatric feeding disorder, as I shown in the previous study, which can have other adverse nutritional consequences. Dietitians would know that exclusion of entire food groups, such as fruit and vegetable, can result in micronutrient deficiency despite adequate macronutrient intake. Children with excessive intake of specific food, beverage, or dietary supplement can experience micronutrient excess, rarely, or toxicity. Excessive energy intake, especially in the setting of lower energy requirement, can result in obesity, weight faltering, feeding skills. Number 3 is feeding skill dysfunction, which is assessed by occupational therapists and speech and language pathologists. So through the diagnostic criteria for pediatric feeding disorder, they will qualify for the diagnosis if there are need for texture modification of liquid or food, if they use a modified feeding position or equipment, or if they use a modified feeding strategies. So any altered feeding experiences due to either illness, injury, developmental delay would have or lead to impairment of feeding skills. For example, in oral sensory function, either if the child is under or over response to sensory aspect of liquid, food texture, that will inhibit the acceptance or the tolerance of food intake. Oral motor function, for example, reduce the strength, coordination, range of motion, timing, would inhibit oral movement, requires for acceptance, control, manipulate liquid and food texture. Oral motor hypotonia can be an impairment, underdeveloped second swallow breathe pattern, poor lip closure, drooling after 1 year old, If the child has a lack of tongue lateralization, loss of food from the mouth, or if the child has impairment in the pharyngeal sensory processing or motor function. Also, if the child is over-responsive or under-responsive to bolus during the pharyngeal transit, or if he has or she has residual remaining post-swallow. Any reduced strength, coordination, range of motion will impact the pharyngeal transit of liquid and food texture. Any individual with pathological difficulty swallowing due to underlying neurological or structural abnormalities. So if you have dysfunction in these skills, you won't be able to consume age-appropriate liquid and food texture. If you have these dysfunction, you won't be able to use age-appropriate feeding utensil and devices. You won't be able, or the child won't be able to self-feed at age-appropriate expectation. The child may not be able to use age-appropriate mealtime seating, or requires more assistance to or special strategies for seating. The child may need prolonged mealtime duration. The child may have insufficient oral intake. We know restriction in mealtime participation can be or can cause safety concerns, such as event of coughing, choking, gagging, vomiting, discomfort, stress, fatigue, refusal, or aspiration. So 8 authors from 5 different professions in the studies, medical doctor, registered nurse, occupational therapist, speech and language pathologist, and dietitian, published their retrospective study that characterized the biopsychosocial characteristic in children with failure to thrive, with a focus on the 4 domains that I mentioned earlier: medical, nutrition, feeding skills, and psychosocial characteristic. You can see in the bar here all the characteristics that I highlighted or outlined in the previous slides. So one of the diagnostic criteria for pediatric feeding disorder is the psychosocial dysfunction. Psychosocial dysfunction is evidenced by the following: active or passive avoidance behavior by the child when feeding or being fed, inappropriate caregiver management of the child feeding or nutrition needs, disruption of social functioning within a feeding context, disruption of caregiver or child relationship associated with feeding. And this will be assessed by behavioral analysis, by ABA therapists, or by behavioral psychologists. So the psychosocial factor will be developmental, mental behavioral health, social, or environmental. What I mean by developmental: if the child has developmental delay, if he has a known spectrum, such as ASD. What I mean by mental and behavioral health: if the child have a diagnosed disorder or the caregiver have a diagnosed disorder, undiagnosed, or if the child have some temperament issue or deregulation. Socially, if the relationship between the child and the caregiver are disrupted. Environmental, if there is a disorganized or distracting within the feeding environment. So the psychosocial impact on feeding behavior can lead to learned aversion, either the child or the caregiver, stress or distress. For example, caregiver will be either disengaged or overengaged. It could lead to disruptive behavior, such as food refusal, gagging, vomiting, elopement, attempt to disengage, or flee from a meal. It could lead to food over-selectivity or failure to advance to age-appropriate diet. It could even lead to feeding habit, although the child has like an adaptive skills or adequate self-feeding skills, but reliance on a formula beyond his chronological age because of the food refusal. Can lead to grazing behavior, or it could lead to caregiver use compensatory strategies to feed the child. And again, you can see in this study, the bar chart, all the characteristics that I outlined in the previous slide are shown in this retrospective studies. So the other component of the diagnostic criteria for pediatric feeding disorder is absence of the cognitive processes, which are consistent with the eating disorder. For example, anorexia. And pattern of oral intake is not due to lack of food or congruent with culture norms. So the multi-factor assessment in this study of failure to thrive and their way of, or the way they showed in this retrospective study, they indicated that better understanding these four factors would be facilitated through a multidisciplinary collaboration and multidisciplinary approach. So they actually recommended that all pediatric feeding disorder should require a team approach of 7 disciplines. So when we assess and treat the child with a feeding disorder, So when assessing and treating a child with a feeding disorder, multiple interrelated factors need to be considered. Therefore, children with feeding challenges benefit most from interdisciplinary and collaborative processes that encourage the family participation, shared assessment between different professionals, and treatment and negotiated mutual goal through an interdisciplinary assessment approach. By using a usage or by promoting a consistent and comprehensive interdisciplinary terminology like pediatric feeding disorder, that will help different professionals to understand the different factors that play in feeding disorder. And hopefully this will lead children with pediatric feeding disorder to have access to all specialties needed for optimal management. So let's talk about the multidisciplinary feeding team. Usually multidisciplinary feeding team will involve medical staff, pediatric GI, developmental behavioral pediatrician, neurodevelopmental pediatrician, pediatric dietitian to assist nutrition, speech therapist, occupational therapist, clinical psychologist, or clinical social worker, and behavior analyst. So usually the multidisciplinary team will see the child and will see the caregiver feeding the child in a monitored room, and all these 7 or 6 disciplines will discuss the child and caregiver interaction. Then after half an hour or after the meal is concluded, either 1 or 2 of each profession will come in and assist the patient individually. So The doctor will assess and treat medical condition associated with impairment and dysfunction. Some multidisciplinary feeding clinic will have a nurse to coordinate the care. They will have the dietitian will assess the dietary adequacy and recommend nutrition therapy. Speech and language pathologists and occupational therapists will come in together and assess and treat feeding skills and swallowing. Behavioral psychologists will come in and assess and treat psychosocial impairment and dysfunction. Either nurse or clinical social worker will help to implement the recommended environmental adaptation to reduce the scope of disability caused by pediatric feeding disorder. So during the multidisciplinary feeding assessment, there will be a medical screening, nutrition assessment, behavioral evaluation, and oral motor skill assessment. Medical screening will involve medical history, physical exam to determine conditions that may contribute to feeding difficulties. If the child needs further testing or medical referral, it will be recommended on the day of the assessment. Behavioral evaluation will involve a detailed clinical interview of the past and current feeding behavior with the parent. Will assess current feeding practices, and they will conduct a formal meal observation with preferred and non-preferred food. And they will make recommendation for the family eating patterns. Nutrition assessment will involve clinical interview to review the growth trend, current and past food intake, health history. For example, if they have a GI reflex disorder, constipation, and will also, the dietitian assessment will include a detailed analysis of the 3-day food intake. Speech and language pathologists and occupational therapists, during their assessment, they will review the feeding history, feeding practice within the family, if the child swallows safely, and they will observe the meal and complete the oral motor evaluation. They will assess if the child has oral hypersensitivity, and they will determine if the child what is the child oral motor developmental skill level. Based on their assessment, they will recommend the intervention, and if the child is safe if the child, they will recommend safe feeding, seating suggestion, and further medical recommendation based on the swallow study, if needed. So multidisciplinary feeding approach has been adopted by many hospitals in the US. Not only even in the US, but also in Canada and many other countries such as UK and South Korea. So I've listed here different known centers in the US, like Marcus Autism Center at Emory University, Star Center in Colorado, Children's Hospital of Orange County, Kennedy Krieger Institute in Maryland, UC Davis Mind Institute, Children's Mercy Kansas City, and many others like Children's Hospital Colorado. Many hospitals in most of the states in the US will have a multidisciplinary feeding clinic or programs. So usually the multidisciplinary feeding clinic in most of these hospitals will offer 2 hours comprehensive outpatient evaluation. During the evaluation, the team of experts will evaluate the child, and based on the 2-hour evaluation, they will provide the family with specific recommendation that will help to progress the child feeding ability. And if they need an intensive intervention, either inpatient or outpatient. So I will give you now, I'll show you guys a brief video now from Marcus Autism Center in order to give you an overview of the feeding, of the multidisciplinary feeding clinic. So I'll share with you the video right now. Miss Malak, let me know if there's any problem with the sound.
The Feeding Disorders Program is designed for children with chronic and severe feeding difficulties. We have a multidisciplinary approach to care with psychologists, dietitians, physicians, nurse practitioners, speech-language pathologists, occupational therapists, social workers, all working under the same roof to provide state-of-the-art clinical care for our patients. Many of the children we work with consume little or no food during meals. The mere sight or presence of food can cause significant disruptions. As a result, many of the clients we serve rely on a feeding tube or formula to meet their nutritional needs. Another subset of kids we work with have extremely narrow diets, so they may only eat 1 or 2 foods at every meal, the same foods at every meal. In both cases, either if you have a limited variety or you're limiting volume of food, it can be extremely stressful for caregivers who are concerned about their child's growth and development. We also offer an intensive day treatment program where children come for 4 meals a day, 5 days a week for 6 to 8 weeks. This allows treatment to have a huge impact in a short period of time for children who otherwise would be struggling with feeding on a day-to-day basis at their home. We've been designing new innovative clinical models that allow parents to be the lead therapist and our treatment team to provide them with tools to be able to do our treatment in the home setting.
And now I will share with you guys the SOS feeding.
When it is time for your child's feeding therapy session, our staff will watch your child while you make it.
Sorry.
Can I help you?
SOS feeding clinic in Colorado. This is the occupational therapist she talks about the feeding, multidisciplinary feeding approach at Star Clinic.
So many people who are struggling with feeding difficulties are misunderstood. I think all of my kiddos have a success story, every single one of them that walks into the door. I'm Kelly Fitzpatrick. I am a speech-language pathologist on the feeding team. I am also the assistant director of the feeding team. The SOS program, it technically stands for Sequential Oral Sensory, but what we really feel like it stands for is Save Our Ship. So many families feel like they're treading water to get their kids to gain weight, gain height, get in their adequate nutrition. And so we use this program at the Star Institute. It's a whole child program and a whole child approach where we are treating the child with a multidisciplinary team. If we're going to challenge these children with feeding, we have to have trust with the child. We have to really develop a relationship with that child, because if a child screams at the sight of salad in that first session and I give them a salad, we're not friends anymore. They're out of there. We really do take a play-based approach to help build the skills for feeding, and especially with the younger kids too. I mean, we're gonna use a lot of their interests to help build the skills for feeding. Oftentimes our kiddos, you know, when they come in for their evaluation, oftentimes we recommend food school. We like to call it food school, especially with our older kiddos. Some kids need a math tutor, some kids need a reading tutor. You know, we're going to food school to help learn how to eat more nutritious foods. We're going to be doing science experiments. We're going to be doing cooking. We're really going to be helping to change the physical properties of the food.
And hopefully this video at Star Institute showed you the multidisciplinary approach, where speech language pathologists and occupational therapists work very, very closely during the intervention after the assessment. Last and not least, we'll go to Chalk Hospital, Children's Hospital of Orange County, where they have inpatient and outpatient multidisciplinary feeding clinic.
Gaining or regaining the ability to eat is a major milestone for a child and their family. We spoke with Dr. Mitchell Katz at Children's Hospital of Orange County who talks to us about CHOC's Multidisciplinary Feeding Program.
What it is we look for children with extreme feeding problems. Our target age group is between the ages of 2 and 6 years of age. Children predominantly who are dependent on tube feedings or have such disordered feeding behaviors wherein they are extraordinarily limited to what they can or will or are able to eat. The majority of our children, particularly the children with feeding tubes, but even those without, have had problems since very early in life. Whether they're identifiable medical problems such as premature infants, children who have had multiple surgeries, multiple medical interventions or surgical interventions, prolonged illnesses. Many of those children develop feeding aversions. There are other situations that can lead to feeding problems, such as something as simple as gastroesophageal reflux, heartburn, allergies. So what we're looking at are the children with extreme feeding problems. This is not a one-off or a one-time experience. These are children who have been doing this for years. And it's our goal to change the behavior, change the dance, teach the child and the parent.
And you can see right now all the different professions are discussing the case either after what they have noticed during the feeding disorder, during the multidisciplinary feeding assessment, or after few sessions, or after the inpatient admission.
Relationship with food and with each other. And that's what a multidisciplinary program is built for, to bring in multiple aspects of and multiple expertise into teaching this child a better relationship with food. Our program is for the worst of the worst, the ones who have failed the primary care provider, the specialists, the kids who are in feeding therapy, who are just not making any headway.
Dr. Katz gave this advice for parents who think their child is having difficulty with.
So hopefully we had some examples of different multidisciplinary feeding clinic from Marcus Autism Center in Georgia to Star Institute in Colorado. So I'm really happy to share that most of the pediatric intensive feeding program are now fully funded by governmental programs in the US, like Medicare or Medi-Cal, or private insurances. And I'm giving you guys example, Cigna, which is one of the biggest or the largest insurance provider in the US. So hopefully, I hope I was able to convince you about this collaborative approach for feeding challenges. This collaborative aspect would ensure that team members make use of their own expertise and specialized skills while assimilating the knowledge and expertise of other team members. In this way, the team will most likely create flexible, functional, and developmental appropriate treatment goal would be responsive to the changing needs of children and their families. And I would like to share with you guys what I have done when during my doctoral studies. Me and many of my co-workers, doctoral resident, Brooke, Beverett, Joshua Brown, Kimberly, and Anjali and Shireen Lalirazi, when we proposed the expansion of the meal time assessment clinic. So we proposed to the Children's Hospital of Los Angeles to expand their feeding programs. And if I hopefully have convinced you about the importance and the dire needs of having a multidisciplinary feeding clinic, then you could use this kind of model with stakeholders or policymakers in the hospital in order to establish a multidisciplinary feeding clinic. So these are the references, but I will show you, it's a PDF file. So I will share it with you guys, if you give me a second. So when you advocate or when you propose for a feeding clinic, usually when you talk with stakeholders, you need to we use this kind of model, and we were able to expand it from 1 day feeding clinic to 2 days feeding clinics. So I'm sharing with you a successful story that we have done during our doctoral studies. So we showed the policy makers and the stakeholder at the hospital why we need an addition day of mealtime assessment clinic. We explain what is the feeding clinic will be, or we call the mealtime assessment clinic, our target population, and competitive clinics within Los Angeles. We described our marketing strategies, how we're gonna operate it, outline the management structure, and our future development to have it run every single day. And of course, many of hospital policymakers will always ask about the financial. How are we gonna fund this kind of clinics, as it requires a highly skilled professions. So usually when you propose your proposal, you will have an executive summary, and then you will have a more detailed plan. So here we describe the program, the history of the program, talked about the industry trends, supported with some research, talked about our target market, more details about our competitors, listed all the competitors within the county of Los Angeles, and our marketing strategies. And we argued that the waiting list for the current, at that time, mealtime assessment was 3 months. So we hoped that by expanding the clinic to be 2 days a week, to cut the waiting list to 6 weeks to 7 weeks. We detailed our operation, where it's going to be held, the extra day. And we were able to convince the policymaker to expand the mealtime assessment clinic, MAC, to be 2 days a week. Hopefully that gave many of you guys an overview of how you write a proposal if you are planning to advocate and request with your coworkers within the pediatric department to have a multidisciplinary feeding clinic. So those are the references. As I said, many of these articles are available online. So I do recommend many of you guys to read it. I hope I was able to convince many of you guys about the importance of having multidisciplinary feeding clinic. Thank you so much for listening, and I'm open for questions.